join. So we'll start. Good morning, everyone, to Medical MCQ for All. I am Dr. Munjal Pandya. Today we are going to take a excellent lecture on medical oncology or oncology, where the most high yield questions, probably we have 10 questions to discuss, but in that 10, I will probably cover almost all the questions related with the oncology. Probably we discuss 50 question in next 1.5 to 2 hours. Right. So as usual, going very quickly, right, for the new students, those who are, first time, right. So we provide basically medical MCQ for all is a company based at India and UAE. We provide PROMETRIC 1000 MCQ book online coaching and subscription. This is the live coaching like what we are taking every day, right? So we provide all live coachings every day in day-to-day practice, right? We provide WhatsApp subscription, we provide Oman Viva subscription as well as coaching. So there are very few players in the market who provide the Oman Viva coaching. So those who are interested, fan and friends, do let us know so we can guide you. A couple of our doctors cracked the Oman Viva as well in first go recently in last week. Data flow services all we provide. Dr. Anjali is in our team who is based at Dubai. So if anybody wants any help from Anjali, feel free to call her. She is in Dubai. We also provide one short package that is excellent, one of the best package so far designed by Medical MCQ. It's a money back guarantee. So those who wants to join, they can join and get back to me or my team for any further information. We have mobile application on Android and iPhone. So those who did not have the mobile application, go and use the mobile application. Excellent web this application because you can use whole the website right from your this mobile applications as well. This is Dr. Munjal myself. I have experience of more than 20 years now in hemato-oncology and bone marrow transplantation and treated more than 100,000 patients and more than 10 years of teaching experience. This is Dr. Aarti. She is a consultant pediatrician and she is excellent coach as well. She is taking care of all majorly pediatric part and other internal medicine. Dr. Maddie already you knows those who are in coaching. So she is an internal medicine and emergency physicians based at Oman. So she is in team. This is Dr. Shikha, who is a consultant gynecologist. She is also taking lectures for gyne. And the good news is that she is going to start one of the exclusive oncology, gynecology and obstetric program in Dubai. So she is shifting to Dubai as well from India. So she will be also available there and maybe in next couple of months. And Dr. Ankit is a gastroenterologist, DNB, super specialized fellow. So he is also taking the lectures. And this is overall team with Pallavi. I think she is calling you and coordinating with you. And this is all our numbers, right? Recently, we had published in January 24 ProMetric 1000 MCQ book. This is the just cover page, right? So those who are interested, they can order the hard copy book as well. And last but not the least, coaching, right? Earlier it was to be a little a big amount, right? 40 hours was 500 USD was the earlier cost, but after a lot of requests from our fraternity, we make it to from 500 to just make it to half the cost. So there is no problem for anyone now joining the coachings as well, right? So just do let us know if you need any help. That's it. So this is what the thing is. So this is regarding the coaching and data flow. As I told you, Anjali Sawant is right the head of data flow. She is based at Dubai. These are her number, mobile, WhatsApp, and email as well. So you call her. Either you call me or Pallavi. So that's it. And one more request: those who have not given the Google review, plus please, I request humbly so give your Google review about our coaching and class, so that will help us to grow better. So I'll share the link just to save the time. I'm not discussing that part now, but after that I'll share a link in the group. So please spare some 1 or 2 minutes and give your genuine opinion. So let's start. You check yourself how we are going today. So this is the mock test of oncology. And this is the first question in front of your screen. 23-year male, mucocutaneous pigment macule and hematomas GI polyp. What is the most likely diagnosis? Is it a Corden syndrome? It is colon cancer? It is Peutz-Jeghers or hereditary polyposis? Right?
Fitzgerald, sir.
Yeah, you can post your answer, doctor. Not a problem. So, as we discussed earlier, there is a triad, right? So, in triad, right, you must know the what is the diagnosis, right? This is the first step you need to know. Another is investigation, how you investigate this patient, and what is the confirmatory test for these things, and what's the treatment. So, in one MCQ, you at least make a three MCQ by yourself, right? So, post your answer, right? What do you think and why it is these things, right? Yes, Dr. Gressel. Can you little bit interact, Dr. Gressel? Any comment, Dr. Gressel? Dr. Amrin? Dr. Amrin? No comment. Yes, Dr. Bahar. Yes, Toprak. Anyone. If you interact, I would be
Yeah.
happy. That would be a more learning, I guess. So we don't want to make it boring lecture. We want to make it very much interactive. So whether right or wrong, don't worry. It's a learning platform. So nothing to worry about right or wrong or what you are speaking, what other people are thinking. Forget about it. You just consider all the question in a such a way that if the same questions comes in your exam, how you interpret. Yes.
So can I?
Yes, yes, anyone, doctor. No need to ask
Yeah, I'm
anyone.
doctor. Okay. It is like sees pets jogger because mucocutaneous pigmentation and hematomatous GI polyps will be in pets joggers.
Okay. So how you exclude from other, like what happens in Coden syndrome, what happens in hereditary polyposis syndrome. So basically our goal of teaching is not just to know the answer, right? But our goal is to exclude the other answer, isn't it? Right? And this is how you probably strengthen your knowledge as well, right? So what do you think? What happens in Coden syndrome?
I'm not sure, sir, about the other symptom.
Fair enough.
Um,
So how do you differentiate from colon cancer?
Weight loss, and I don't see the mucocutaneous pigment macules will be there in colon cancer, but weight
Excellent.
loss will be there, constipation or diarrhea, or patient will be like yes, sir.
Yes, great. So that is excellent point. So here again, the age is a controversial for CA colon, isn't it? Because 23 years is quite young age for development of colon cancer. What do you think, right? And as there is a no other history, like as you rightly said, no history of diarrhea,
Yes,
no
sir.
constipation, no obstructions, right? Or no other colonic mass in sonography or endoscopically finding, no
Yes.
history of bleeding PR. So that's all against the colon cancer, right? So every time whenever we are,
Yes.
answering any questions, you need to exclude. So try to make a habit from now that, okay, fine, Putzagger is the answer. But why these three are not answer?
Cowden, I think I'm not sure. Cowden will have, I think, hamartoma syndrome, multiple, like in oral, acral, palmoplantar. I
Great,
think there will
wonderful.
be
You are
keratosis
going
will be
on a
there.
right track. You are going on a right track. Perfect. And last but not the least, what gene responsible for the Putzagger syndrome, doctor? What's your name?
Dr. Preeti, sir.
Dr. Preeti, yeah, sorry. So what's
Hello.
the syndrome? I mean, sorry, what's the gene involved with Putzagger syndrome? That is another question. So if you they give you the list
Uh,
of the gene,
okay, I'm not sure. Hmm.
right? So what could be the gene?
I'm not sure
So
about the genes. It is an
yeah,
autosomal dominant.
yeah. So this gene is this STK11.
STK11, it's a
STK11
19
gene,
thing.
right? So STK11 gene mutation testing is the answer for this. So if in chance, right? See, 80% of the questions are very easy and understandable. 10-20% questions are tricky. So I'm not always trying to make a very lollipop questions for you guys. So you are very happy. Oh, I got a 10 out of 10, and in exam you find something else, right? So you need to also, prepare yourself for little tricky questions. So this is tricky. Which gene involved? It's a credit question. So this is the clinical diagnosis of Peutz-Jeghers syndrome requires the presence of any one of the following, not all. Any one of the following is there, it would be okay. two or more histologically confirmed. So you do the colonoscopy, endoscopy, and you confirm, right? Any number of PJ, Peutz-Jeghers polyp detected on individual who has a family history. So one is like without family history, right? Histologically you confirm. If you have family history, right, then you can confirm characteristic of mucocutaneous pigmentation, which is not seen in other disease. What A, B, C, D given, except Peutz-Jeghers, mucocutaneous pigmentation is not seen. And any number of PJ polyp in individual who also have characteristic mucocutaneous pigmentation, right? So you have a polyp plus mucocutaneous pigmentation, it is none other than PJ or Peutz-Jeghers. And if the criteria is met, so if you have either 1, 2, or 3, 4, any criteria is there, either family history or biopsy proven or histologically proven, it's there, then you don't need to worry about anything. You just go ahead with the one test that is called as STK11 gene mutation testing. So if this criteria is met, patient has to undergo for the STK11 gene mutation testing. And if it is positive, it is 100% confirmed that this is a Peutz-Jeghers syndrome. That's it. So this is what the thing is. This is a clinical picture. This is how it looks like, the mucocutaneous pigmentation. So why this is important to understand this rare disease? Though it's not very rare, the incidence, if you can see, prevalence 1 in 25 to 2.8 lakhs. In autosomal dominant disease gene, as I told you, STK11 is involved in it. Hematomas and adenomatous polyps, especially in the small intestine, right? And why this is very important? Because it increases the risk of many cancer. Number one is a GI cancer, either stomach, esophagus, or colon. Second thing is it also increases the risk around 50% to a breast cancer. It will also increase the uterine cancer, and it also increases the risk of the lung cancer, right? So it is, and also obviously it's not excluded ovarian and sex cord tumors, right? So gynec cancers, breast cancers, lung cancer, colon cancer, or GI cancer. So this is very, very important things. And this is labial and oral mucosal hyperpigmentation. So you can see here the labial, right? And on face, there is a mucocutaneous, mucous membrane, as well as cutaneous, means skin pigmentation. So this is classical picture of Peutz-Jeghers syndrome. So always keep in mind, right? Another slide, probably not much directly related with it, but important in context to the colon cancer. So every time when the colon cancer things comes, we are always confused ourselves. So don't get confused. Why this Peutz-Jeghers is important here? Peutz-Jeghers, as I told you, it increases the risk of colon cancer. So Peutz-Jeghers syndrome, PJ syndrome, right? The guideline for sigmoidoscopy or colonoscopy, you can see here the sigmoidoscopy every 1 to 2 year. It's quite, and what's the age? You can see 12 years. So very, very extremely early age, 12 years of age, right? You, or every 1 to 2 year, you need to do a sigmoidoscopy, right? And find out the polyps. If it is there, you can biopsy. If it is confirmed histologically, you can go for that gene 11. Is that clear to everyone? Yes or no? Preeti, is that clear?
Yes, sir. Yes, sir.
Wonderful. So this is one thing by which, I mean, we need to know about the Peutz-Jeghers, because it increases the risk of GI cancers, colon cancer, rectal cancer, plus breast and tubo-ovarian cancer and lung cancer. So this is very important. Now see, this is the twist. So whenever they are asking lots of questions about colon cancer, 50 years of male presented with anemia, what is the best investigation? Colonoscopy. Colon cancer, right? So this is the most important. And colon cancer, the screening or early detection, right? This is extremely high yield questions for any exam. Believe me, any irrespective of hard DHA, MOH, OMSB, whatever. You must know this chart. So what is the general population guideline? General population means population who does not have any sign symptom. They are absolutely healthy. Like your father, my father, your mother, my mother, right? So our family friends. So they everyone is eligible for this general population. So what in general population? Colon cancer screening. This is screening test, right? Screening. This is not diagnostic. This is screening. So screening is what? Before any sign and symptoms develop, you are going to do some investigation by which you get to know, right? That early detection you can possible. Like mammogram is a screening test. Pap smear screening test. Colonoscopy screening test, right? And screening is done when the patient has no sign symptom, patient is absolutely healthy, like our father mother, they are fine. You, if they are more than 50 years of age, you must do it the colonoscopy every 10 years. So what is the start age? So one question here, what is the start age of colonoscopy in exam? 50 years of the age you start, and what is the end age? 75 years is the end age. So you stop at the 75. What is the frequency? So this is one question in exam. Second question is, at what interval you supposed to do? Every 10 years. So you start at 50, then 60, then 70, right? Up to 75 you need to underwent for mammogram, and this is for the general population. General population means population who does not have any sign symptoms. So start screening at 50. They have not written here, but it is a guideline anyway, so I'll just make it for your more convenience that what time you stop. So 75 you need to stop, right? Colonoscopy, what is the frequency? At every 10 years. So these two things you must remember, when to start and at what frequency. Now little twist in the second questions. This is a twist in the second question. What if single family member with colon cancer? So somebody you have a, right, in family friend there is a colon cancer, right? Single family member with colon cancer, and now they are asking, right? Then when supposed to start the screening for other members, right? So single family member with colon cancer, what is the guideline for colon cancer screening? So start screening at 40. So here the 50, right? Here the 50, normal population 50. So considered in that way, it's a 10 years earlier. So it's a 40 years, 10 years. So start screening at the 40 or 10 years earlier at the age at which the family member contracted the cancer. So if family member contracted the cancer at 45 years of age, example, right? So you have two options. Either you go for the 40 or you go right at 40 as per this guideline, 40 years or 10 years earlier. 10 years earlier is 35. So which one is earlier, you should pick up that, right? So they are, what they are saying, start screening at the 40 or 40 years or 10 years earlier than the age at which the family. So latest by latest you should do at 40, latest by lately. But if you can start at 35, it is well and good. So this is little twist, right? So here what the change is, right? First general population start at 50 to 75 every 10 years. That's it. What is a little change here in some single family member, instead of 50, now you start at 40, at least 40, right? Second, third, even more complex. This is single family member, here three family members, two generation means me and my son daughter is two generation, or my father and me is a two generation, right? Like that. So three family members within one family, either three family member or two generation, or somebody is less than 50 years of age, right? Then what to do? Now see, the screening is almost half. Here 50, here directly 25. Somebody with a three family member and two generation. Colonoscopy every 1 to 2 year, here every 10 years. So frequency is increased. Why? Because these people are at increase the risk of developing the colon cancer, right? Because three family member means high, very, very high. Even this could be a some syndrome, right? Can anyone tell me, when there is a lots of family members with colon cancer, what other condition or syndrome you can think of? Anyone? So if you don't know, you just go and read it more. It's again a questions, right? So you need to think of some condition. Also, syndrome. So again, three family member, two generation, less than one, colonoscopy 1 to 2 years, starting at age 5. So general population 50, three family member 25. It is here 10 years, it is 1 year. So remember 1 to 2 year. If you are answering 1 year, it's not wrong. 1 year or 2 year, but max 2 years, right? FAP, familial adenomatous polyposis, that is FAP. Gardner syndrome, Peutz-Jeghers and Turcot. These are the three. Ratify this four name: familial adenomatous polyposis, Gardner, Peutz-Jeghers, and Turcot. What is here? The Peutz-Jeghers I already told you. Even this is the most highest risk, most highest among 1, 2, 3, and 4. Which is the highest group, right? Who develop the colon cancer or GI cancer or other increases the risk. This is the 4. Here, see, every 1 to 2 year, and frequency is 12 years. So if you multiply, 12 multiply is 24, but I can take 25, and 25 multiply by 2 is 50. So 12, 25, and 50. So see, the general population is 50 years, three members 25 years, one family members 10 years earlier, three members is 25, and this all four syndrome is at 12 years of age. And last, juvenile polyposis, no extra screening recommendation. No extra means what? It is as per the routine, right? It is not a cancerous condition, it's a benign condition, right? So no need to worry, but still you need to do as per the general population, irrespective of the things. Is that clear, Preeti? Anyone?
Yes, sir. Yes, sir.
Yeah. Any confusion? Anyone? Any questions in the house? So you must go and read the colon cancer, right? Once again, complete whole chapter of colon cancer. What is colon cancer? What is the common histology? Do you know what is common histology, Dr. Preeti, in colon cancer? If you have a mass in the colon, patient has a mass in the colon, rectosigmoid junction, right? And biopsy was done from that mass. What you expect the common histology?
So your voice is breaking, sir.
Yeah, now it's better.
Yes, sir. Now it's better, sir.
Yeah, so I'm saying what is the commonest histology in colon cancer? So adenocarcinoma.
Okay.
Excellent. Adenocarcinoma, Saima. Well answered. So adenocarcinoma is the commonest histology. So you must need read. So what you need to read in colon cancer questions, 110% many question comes from this in different way. So you cannot miss, right, to forget this chapter to read properly. So whole colon cancer, what is colon cancer? What is the histology of colon cancer? What are the screening program of colon cancer? So if you remember this one this chart, almost done. They won't ask you out of this chart. But this chart is complicated, confusing. We have seen many times, but we forget. But probably my explanation will help you. So probably you better understand now. So this chart again, you have to read again if you have any confusion, right? So colon cancer, diagnosis, symptoms, investigations, colonoscopy, screening, basic treatment, right? And histology. That's it. So this is what we need to do. Let's jump to the second questions, right? So 36 years old man is diagnosed with superficial spreading malignant melanomas. Which one of the following factor will determine the patient's prognosis? Size of the lesion means bigger the size bad. Shape of the lesion, irregular shape, regular shape. So irregular shape has bad prognosis. Thickness of the lesion, deeper the penetration of this melanoma, bad the prognosis is color. So fast changing in color of the lesion is bad prognosis, and patient age is a bad prognosis. So what do you think? What is the things? Just take 10-15 seconds. Every time I'll not going to ask you very tough questions, don't worry, but you need to prepare for the exams. You don't take it lightly that okay fine, this is a toxic topic, nothing will come from this. But believe me, there are a lot of questions come from that only. So you are in trouble, and I don't want anyone to be in trouble, especially you are taking my coaching and making yourself in trouble is not good idea. So we have many people in the house, but only I got the answer is 4 5. Dr. Yogpriya, you can post your answer. Jomoli Muzni Mubarak, Onkar, Roshan, Saidi, Saima, Vidya, all you post answer. All you post answer. Right or wrong, don't worry. All you post answer. Okay, great. So I think most of the people in house is the correct answer, right? Anyone wants to comment on this, right? Unmute your mic and discuss, no problem.
It's
Yes.
important type of invasion.
Sorry.
Show high risk of melanoma is deep of invasion. So
Okay.
it's think as
Okay. So this is the things. ABCD, you must have know the ABCD, right? Of melanoma, yes or no? Have you heard of ABCD of melanoma, yes or no?
yes.
Yes.
Great, wonderful, wonderful. So ABCD of melanoma is important. One second. Great. Okay, so ABCD is A stands for asymmetry. So what is the asymmetry? This is a very much symmetrical lesion, normal. This is very irregular. This is asymmetrical. So this is hallmark of these things. B means border. Borders are regular. Here the irregular, right? This is color. So color usually non-melanomatous lesion. It is a uniform. Here is not uniform. Some dark, some hazy, some dark, some light. So it's a signs of cancer anyway. So color is like a mole that has more than one color. So in one mole you can see two three different color, while this is the one same symmetrical whole color, one color in whole the lesion of the skin. Diameter, mole with a diameter larger than a pencil eraser, or you can say 6 millimeter, right? So this is diameter. And evolution, a mole that has gone through the sudden changes in a size, shape or color. So this is before 6 months, size, shape and color would be the same, while in melanoma, size, shape, and color would be the different, right? As we discussed. So ABCD, asymmetry, border, color, diameter, and evolution. So just keep in mind, sometime they may ask you the questions related with the diagnosis, right? So what could be the diagnosis? So if change in the size, shape, color, border, content of the lesion, right? And evaluation means they grow usually faster in size, shape, and color. So this is the general understanding of melanoma. This is another question. What classification can you use, right, to prognostify this melanoma? So name of the gentleman who has given this is a Breslow. So this is Breslow's classification, Breslow depth. That is why the name comes Breslow's depth. So Breslow load thickness is the single most important prognostic variable, distance in the millimeter of furthermore tumor. Fine, I'll explain you. So basically what is the things? So the Breslow thickness is what? Say for example, this is skin, right? So in skin there are many cells. One of them is a melanomatous, right? So melanin. So from melanin it arises is a melanoma. If it is arising cancer from squamous cell, it is squamous cell carcinoma. It is from basal cell carcinoma, right? Like that. So squamous cell, basal cell, melanoma, that is melanin. So there are various cells in the skin, right? So this melanoma, right, is the melanin it starts, right? So more higher, see, if it is a this size, less dangerous. If it is more size, more dangerous. If it is a more deeper, it is more dangerous, right? So more the depth of the lesion, right, that increases the risk of recurrence. Also the prognosis is poor. So low, medium and high, you see the low, here the medium, and the more the depth is a high. So this is epidermis, dermis, and this is fat layer and blood vessel, and then subcutaneous tissue, muscles, and bones. This is how it comes. So melanoma is arising from the melanin, and depth of the lesion, it gives you the overall survival. On the right side, now you can see if it is less than 1 millimeter spread, not centimeter, huh? Forget about centimeter, it's a millimeter. So less than 1 millimeter of thickness, right? 95 to 100% 5-year overall survival. So those who have just less than 1 centimeter, right? If you pick up and you excise completely, right? If you remove the complete tumor, right? Then there are 95 to 100% chances of cure, or patient may survive almost 100%, means all this is cure basically. 5 years is cure. So if it is 1 to 2, just 1 millimeter increase will reduces the I mean 5-year survival from 100% to 95%, and from 2 to 4 centimeter it is 75%, and more than 4 millimeter, sorry, is a 5-year old survival is 50%. So if 1 year 100%, but 4 millimeter or more depth of the lesion is a almost 50% survival is reduced just by increasing 3 millimeter. So it's a depth is extremely important, right? So not the size, not the shape, not the color, but depth of the invasion of melanoma into the layer of the skin decide the prognosis, and this is called as a Braslow's thickness or Braslow's classification. The thickness of the lesion in which is known as a Braslow's thickness measured in the millimeter will determine the patient's 5-year overall survival. As I told you, the Braslow's thickness can only be determined once a excisional biopsy of the lesion is performed. So obviously, how do you get to know? right? So what is the base treatment? What is the base treatment of malignant melanoma? So base treatment is to excise the lesion, excision of the lesion. So once you excise the lesion, you can do the histology. Okay, fine, this is melanoma. Number one, by excising, you get to know how much depth involved, right, from up to down or from the whole thickness. Is it 1 millimeter, 1 to 2, 2 to 4, more than 4? So that is how you get to know the things, right? And more the depth, higher the risk of metastasize this melanoma to the other parts of the body, especially lung and bone, right? They usually metastasize. So that also decide the prognosis as well and aggressiveness of the tumor as well. Because sometimes if it is some patients present with the advanced stage 4 with the bone and lung mets, then what will you do? You need to give a chemotherapy. You need to give a chemotherapy, right? Not just the excision is treatment. Excision is the only treatment when the disease is localized, but when disease is metastatic, you need to add the chemotherapy as well. Is that clear to all? Yes or no?
Yes, sir.
Yes.
Wonderful, wonderful. So again, this is a homework for you. Read melanoma. This is very frequently asked questions. I try my level best to compile a lot of questions in one things. Third questions, extremely important. A 52-year-old smoker has 1.5 centimeter calcified nodule found on the chest X-ray done for the other reason or routine checkup. He has no symptoms. What would you do? Right. So this is the gentleman who has a right on an incidental or on the routine evaluation, he found to have a lung 1.5 centimeter nodule in a lung. So he has just only single solitary nodule in the lung. Otherwise, both the lungs are normal, clear. Patient is asymptomatic. There is no problem, right? And what they are asking now, what should you do? So is a 52 years male. Keep in mind, 52 years of male, and he is a smoker, right? He is a smoker, so tobacco history is there, and he has a solitary nodule, just 1.5 centimeter calcified nodule. It can be seen here on the X-ray. So now you are going to do excisional biopsy, you are doing CT scan, you are doing PET CT scan, you are doing bone scan, you are doing mutation analysis or further genetic test. What will you do? Yes, so Yog Priya, if you can little explain PET CT scan, I would be happy if you are in position to discuss. Yes, Yopriya.
Sir, we can do PET CT and we can see the involvement of if there is any tumor or is it only the solitary nodule or the extent of its um,
So did you confirm
so
that this is a cancer?
no, after doing biopsy, for biopsy also we need to know so that
Sorry, I'm still little confused with your answer. So first of all, decide this condition is benign, malignant, or likely malignant.
so then maybe we can go with biopsy, sir.
So
Then
why?
PET
So
CT.
without doing biopsy, why you want to do the PET CT then? What I mean, say for example, just understanding, right? It's a learning. So you are suspecting one person as a lung cancer. So after you did a PET scan, just for discussion, you did PET scan. So what additional information you will get in the PET scan in this patient? You did PET scan, I'm fine. You did PET scan. So what additional information you'll get it on PET scan? Or what is your logic, or being a doctor, what you want to evaluate in PET scan in this patient?
By PET scan, we can also rule out is that uh, cancer tumor or is it only involved in lung or is there anywhere else?
Fair enough. So metastasis is there or not, we can know, right? That is what you want to say, right? Whether it is
Yes, sir.
limited to lung or another lung or bone, liver, brain, it's spread or not. So that we can get the information. Okay, fine. What else? So
Last time CT scan is clear. We can't say he is not cancer. We should make excisional biopsy for be sure cancer or no cancer.
Okay, so now basically this is a suspected case of lung cancer. Suspected. Why? Positive points are age more than 50. So it's a 52. History of smoking, it's a cancer. Anything more than 1 millimeter, sorry, 1 centimeter size, right? Calcified nodule in a cancer again goes in favor of cancer, right? Though even it is cancer, symptoms is there or not, it's a different issue or it's a different thing, right? If symptoms are not there, doesn't mean that there is no cancer, right? Patient 50 years of female presented with a breast lump, right? And she has no symptom, doesn't mean that she does not have breast cancer. She may have breast cancer because breast cancer's lump is a painless. 99% of the things what I am seeing in my practice for last almost 2 decades is a painless breast lump. First symptoms of breast cancer with the female, if the female is a postmenopausal or more than 50 years with painless, no pain, painless lump is the most commonest presentation of breast cancer. So this patient may also have, na? The patient has no symptoms, but he may have a lung cancer, right? So first try to confirm the diagnosis by doing the biopsy, and it is solitary. So what is the literature says? Excisional biopsy should be done on a solitary lung nodule. See, excisional biopsy, not incisional. You need to excise the by because it is small. So anything more than 1 centimeter in size, solitary biopsy can be done from the solitary lung nodule in patient who are smoker. Even forget about age. Smoking is more important. Age more than 50 lends additional urgency to need for the biopsy. Even though if the patient is 45, I will do the same thing. But it is again a more than 50 years of age, solitary nodule, smoker, and 1.1 centimeter, more than 1 centimeter of calcified nodule. You must do the excisional biopsy. So you do the excisional biopsy, and history of smokings are important, right? So lung cancer screening should be performed. Now another question in exam. So this question is over. If somebody has suspected lung cancer, solitary nodule more than 1.1 centimeter with smoker, go and excise it. That is the answer. Once you excise Yogpriya, you confirm that okay, adenocarcinoma, squamous cell carcinoma, small cell carcinoma, you confirm the diagnosis. Then your second step is to go for the PET-CT scan. Why? Because the treatment now you just need to you excise the lung a lesion, right? But you don't know whether it is spread to other parts or not, right? So you did the diagnosis. But if this patient has a lung opposite lung nodule, this patient has a liver or bone or brain metastasis, then you need to further treat these patients by various modalities, by the chemotherapy, radiotherapy, targeted therapy, immunotherapy. There are a lot of modalities available now for the lung cancer. So excisional biopsy will not help you alone when there is a disease in some other parts of the body as well. So first do the excisional biopsy, then do PET scan, and then treat the patient as per the histology of the patient. So we'll discuss that, right? So this is how it works, right? So those who has given the answer of CT scan or PET CT scan, it's not a good idea in a first stage. First, you do the diagnosis by doing the biopsy. Once the biopsy is done, you can go for the CT scan, PET CT scan, or even bone scan as well, right? If it is localized just before treatment or before doing the surgery, right? Or before doing the lobectomy or major surgery, you must know that it is not spreaded in the other part of the body, and that is why the staging workup is needed. So it could be CT scan, it could be MRI, it could be PET or bone scan, because lung cancer commonly goes to the bone, right? So that is why bone scan, and there are lots of genetic and targeted therapies now available. So mutation analysis is also important, but everything will come. B, C, D, and E comes after biopsy. That's it. So first you need to do the biopsy. Is that clear, doctor? Yes or no?
Yes, sir.
Yes, sir.
Yog
Yes,
Priya, you get the point,
Yes,
right?
sir. Yes, sir.
Wonderful, wonderful, wonderful. So now what's the another questions in exam for lung cancer? So lung cancer screening should be performed in all smoker more than 30, like colonoscopy we have seen, right? General population, one relative, three relative, and Putzacker, right? Four category. Like here, there is a category to whom to do, to whom not to do. So anybody who does not smoke in lifetime, they are not a good candidate for lung cancer, because smoking 90% plus patients, lung cancer develop they are the smoker. So lung cancer screening should be performed in all smokers with more than 30 pack a year of smoking history between 55 to 75. Colon, the age is 50 to 75. Colon is 50 to 75. Here 55 to 75. Just for your knowledge, I'm repeatedly doing, right? So lung cancer screening should be done in 3 criteria. Age criteria 55 to 75, somebody who is a smoker, and how much smoking, 30 pack per year. So 3 things you need to remember. So in your society, your family or your friend, 3 criteria. If somebody is smoker, yes, he deserves age preferable 55 to 75, and how much, 30 pack. They are the highest, most qualified candidate to do the lung cancer screening. And again, another question, how you gonna supposed to do the lung cancer screening? So chest CT scan should be performed. For colon, colonoscopy. For breast, mammogram. For pap smear, cervical cancer. Lung, low dose CT scan. That's it. So CT scan, the more specific word is a low dose CT scan should be performed, right? For all these 3 category, 55, 75, 30 pack smoker. That's it. And lung cancer screening, the same thing, right? So this is what the thing is. So you must remember, because they probably asked you this question as well, right? Whom to do, whom not to do, right? So this is what the thing is. I'll share this PowerPoint with you so you can read again later on. Don't worry, right? So next questions in front of your
Sir,
screen. Yes, please. Question.
sir, I have a doubt, sir.
Yeah, yeah.
Sir,
Ask.
CT screening, any interval, sir, after 50 years we have to do, and after that, only one time or?
No, 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 not only one time, sir. Doctor. The frequency. You are asking the frequency, right?
Yes, sir, yes, sir.
So frequency should be done at the first, at the baseline, right? Say 55 smoker comes to you, heavy smoker, so you do it at 55. After 1 to 2 years, you can repeat it at least annually.
Okay, sir.
Another question in exam, to you, which is the most common cancer in female and which is most deadliest cancer in female? Two different answers. Anyone? Which is the most common cancer in
Breast
female?
cancer
So
and
answer is,
cervical cancer.
yeah. So
Adenocarcinoma.
yeah, so basically the answer is a breast cancer. We'll come to the breast cancer in next slide. So just
Cervical.
so no, breast cancer is the most common in India, in Middle East and across the globe. So breast cancer is number one and then cervical cancer. So what my question was, what is the most common? Answer is this breast cancer, right? What is the deadliest, most dangerous cancer in female? What's the answer? Lung cancer. So the common, right? So maximum cancer in female is breast cancer, but maximum female die because of cancer is a lung cancer. So most deadliest is lung, most common is breast. So don't get confused. Is that clear? Yes or no? Yes or no?
Yes, sir. Yes, sir.
Yes, sir.
Wonderful. Wonderful. Next questions in front of your screen. A 30-year-old woman complaining of bilateral breast enlargement and tenderness, which fluctuates with her menstrual cycle. On physical examination, the breast feels lumpy. There is a painful, discrete 1.5 centimeter nodules in the breast. A fine needle aspiration draws clear fluid, and cyst collapses with the aspiration. Which of the following is the next step in the management? Are you going to do the clinical breast examination in 6 weeks? You go for a core needle biopsy. You gonna do mammogram, bilateral mammogram, just to make sure that there is nothing other breast, or repeat FNA in 6 months or ultrasound in 6 months. Think over it. 15 seconds for you. So just don't get hurry, right? Try to give a proper answer.
Answer A.
Okay, let's other doctors to answer. We'll discuss. Yes. Yes, again, Yogpriya. Why it is a C mammography, Yogpriya?
Bilateral breast enlargements and the lump is seen only on the one unilateral or bilateral, sir?
You can
This
figure out. Questions is in front of your screen. They are saying bilateral breast enlargement. The chief complaint of the patient is a complaint of bilateral breast enlargement and tenderness, which fluctuates with her menstrual cycle.
and no, sir, the lump is on only unilateral side. So just make sure that we could do mammograph.
Okay. So are you thinking of breast cancer in this patient?
30-year-old but the fluid is clear liquid. Maybe it's a cyst.
So what fluid on, say for example, there are hundreds of criteria by which clinical, radiological, histological criteria for diagnosis, isn't it, right? Say for example, some patient has a chest pain. So before doing anything, we think of, oh, this could be acute coronary syndrome or acute MI. This is a clinical thing. Then how you confirm? By doing the ECG and enzyme. You confirm. Okay, fine. This is sir, acute coronary syndrome. Then treatment. You do PCI, you do thrombolytic, blah, blah. So here the same thing applies. Now, for every patient, first you need to do the clinical diagnosis. Second, you need to do the radiological diagnosis. And then you need to confirm the diagnosis by doing the histology or histopathology, blah, blah, right? So you have three modules at least by which, right? One is clinical, radiological, histological. By all three means, you can suspect, you can diagnose the things. So do you think clinical background? So what you tell me, Yogpriya, if I tell you the fluid, right, comes from the cyst is a bloody and fluid comes is a, I mean, clear cut watery. What is more likely of cancer? Clear fluid is more likely cancer or blood is more likely cancer?
Blood is more likely cancer, sir.
Fine, wonderful. So you knows everything, but you little confused. So do you think that there is a blood? What the word mentioned here is?
Clear fluid.
So less likely. 1 point is against breast cancer. Number one. Number two. Do you feel that 30 years is a good age for development of cancer? I mean, I have 18 years of patient. Is exception is always there, but it is like once in. So Yogpriya, you can unmute and tell because there are a lot of things. So I muted all. So you can interact with by doing unmute. Yes, Yogpriya, are you with me?
Yes.
Right. So this is less likely. Just listen right now. Uh, bilateral breast enlargement. So usually at 30 years of age, you can't see the bilateral breast cancer. Extremely important thing, breast cancer never fluctuate with the menstrual cycle. It has nothing to do with the hormonal cycle, right? Whether it is a fluctuate means what? Increase and decrease, right? So when there is a periods, increase in size. When periods off, it's decrease in size. Breast cancer patient, I've seen hundreds and hundreds of patients in last 20 years. They never have any correlation with the menstrual cycle. If it is 5 centimeter, then it is a before menstruation 5, during menstruation 5, after menstruation it 5. It will not fluctuate. Are you getting my point? Yes or no?
Yes, sir.
Right? And it is a painful. So breast cancers are never painful. 98% of the breast cancers are painless. Here the painful. There is a painful, right? So age again breast cancer, bilateral breast cancer, enlargement again breast cancer, fluctuation is against breast cancer, right? Pain is again breast cancer, and most extremely important. So clinically we have seen that breast enlargement with the menstrual cycle. So this is clinical, right? And another thing is what? The histological fine needle aspiration show clear fluid, right? And what the extremely important, cyst collapses with the aspiration. So which is not collapse with the aspiration? Cancer. Cancer never collapse with the aspiration, right? If you aspirate, it will refill. It will not collapse. Again, in 4 to 6 weeks, it refill. So this picture in general, considering the age, considering the bilateral with the menstrual fluctuation, with the pain is most important factor, right? Either it's an inflammatory breast disease or, right, or it is a benign. Pain is usually not there in breast cancer at this age. It could be fibroadenoma, painful, right? Or cystic lesion in the breast cystic disease, right? So this is what the thing is. So here the answer is a clinical breast examination in 6 weeks. So you do in 6 weeks. What is the advantage? You tell me why you want to do, anyone, open for all. Why you want to do a clinical breast examination in 6 weeks? Tell me. Your answer is correct, but why you want to do it? That is more important.
To check the reappearance of the cyst, or
Ex
again it is refilling or not.
Excellent. So this is what the concern is. So if this is a benign, then once you aspirate completely with the clear fluid, it won't reappear. It is almost gone for at least few months to years. It will not fill up. But if it is a malignant, then the cyst is reappear, cyst will refill, cyst may probably change the color, cyst is now red, right? And you aspirate now blood, then it is highly suspicious of malignancy. So in context with the whole questions, now you first do the clinical breast examination in 6 weeks of time. If everything is fine, nothing to worry. That's all. No biopsy, nothing further investigation is needed. If it is a cancer, then you need to do blah blah blah, all the things. You do core needle biopsy, blah blah. Right, and it's a lot.
Sir, why
I
can't it be ultrasound? Sweet.
sorry, let me go back. Ultrasound in 6 weeks. So you tell me, why can't it be ultrasound? What's your thought is? So why you want to do the ultrasound? Why you don't want to do the clinical breast examination? Or why you want to clinical breast examination? Why not ultrasound? Other way around, both the questions. So what do you know, doctor, by doing the ultrasound of the breast? Tell me. Whenever you advise any patient that okay, you do ultrasound of the breast. So what information you will get by the ultrasound? You get something, na? You speak up, don't worry, right or wrong.
Most probably get the if there is a fluid accumulation. Most
Exactly.
commonly you would be able to quantify that it's very little one or
Fine. So basically the ultrasound of breast is done. So first of all, it will give you the idea whether breast, the primary object of doing breast ultrasound, whether it is a cystic or solid. You understand? Whether it is a cystic or solid. Solid is more goes in favor of malignancy. Cystic is more goes in favor of benign lesion, fibroadenoma, fibrocystic disease of the breast, right? Fibroadenomas, right? Like that only. So that will give you, but it is important when it is refill, when it is a recur, when it is a refilling of the things again, then it is important. So first do the non-invasive things. Okay, when after 6 week patient comes, you feel that okay, fine, lump is gone or not. Oh, lump is gone, patient has no pain, patient is fine, there is a no local sign symptoms, no axillary lymph node supraclavicular, patient is asymptomatic. Let them enjoy, no need to do any investigation. If but with this patient again comes within 6 weeks with refilling, with change, then you must do the ultrasound. After doing the ultrasound, again you repeat FNA, and if required, suspicious of malignancy after 6-8 weeks, then go for core biopsy. And if core biopsy confirm the things, then you do the mammogram and you do PET CT scan, then you do the staging once the biopsy confirm, and then start for the treatment or go for the treatment. Is that clear?
yes, sir.
Got it. So first
Yes.
give the priority to non-invasive, right? This is breast. This is the most easiest and simplest. If there is something wrong, then you first jump on the ultrasound or mammosonogram, then biopsy, then staging PET CT scan, and then treatment. Any question? Any question? Yog Priya, you understood?
Yes, sir.
You got the idea? Any question?
No, sir.
Wonderful. So this is general classification. I made it benign breast disease and malignant. So benign is fibroadenoma, fibrocystic disease, intraductal papilloma, fat necrosis, mastitis. This is all benign, nothing to worry. Malignant is all ductal carcinoma in situ, lobular carcinoma, invasive inflammatory, and Paget. So these are the kind of malignant, right? So you must remember what are the malignant, what are the benign. I will discuss all this in next questions. Great. 68-year-old woman present or visits her physician with solid peanut-shaped hard mass in upper outer quadrant of the breast. Biopsy of the lesion reveals infiltrating ductal carcinoma. Which of the following is the next step in the management? Lumpectomy with a lymph node sampling plus radiotherapy, modified radical mastectomy, modified radical mastectomy plus radiotherapy, neoadjuvant chemotherapy plus lumpectomy plus radiotherapy, or tamoxifen and radiotherapy. Your time starts now. Yes, Dr. Saidi, can you little bit interact with me if you don't mind?
Yeah, yes, sir.
Yes.
Hi,
Your
sir.
answer, how are you, sir? Your answer
Yeah,
is D, right? Neoadjuvant
yeah,
chemotherapy. So
exactly.
now justify me. What first of all, what is neoadjuvant chemotherapy? Tell me.
Uh, I just only thought about chemotherapy.
Okay, fine. So keep a word apart. Neoadjuvant that I will discuss. Chemotherapy plus lumpectomy plus radiotherapy. So why you want to do the chemotherapy right now for this patient? What are the indication of chemotherapy first, not the surgery?
Yeah, indication is because she has to take tamoxifen for long to prevent the recurrence.
Okay. So tamoxifen, why you want to give the tamoxifen to this patient? What is ERPR? Positive or negative? When you supposed to give tamoxifen, or tell me what is the tamoxifen first of all? You need to know everything, doctor. Now this
Yeah.
exam people are going more tougher, believe me. I'm not trying to scare you. I'm just trying to make you understand before going for the exam, right? So I would be happy at least you are interacting with me, right?
Mm.
So let's see. So do you have any idea about tamoxifen or no?
Yeah,
So tell me two line, whatever you knows about tamoxifen, whatever you knows, you tell me.
yeah, it's a hormone therapy basically.
Okay, great.
It's
It's a
used to,
hormone therapy which acts against what? Progesterone, estrogen.
um, estrogen blocker. It is definitely
It's a estrogen blocker. So another simpler word is a anti-estrogen, right?
anti-estrogen. Yeah.
Anti-estrogen,
Yeah.
right? So you are absolutely right. So tamoxifen is a selective estrogen receptor modulator drug, or simple name is anti-estrogen, tamoxifen, right? So what is the side effect of tamoxifen? Two common dangerous side effect of tamoxifen. Exam question in DHA.
One is kind of like it, but now she's 68 years. It doesn't matter. But if it is in a younger lady, it can cause like uh, premature menopausal symptoms.
Okay, so that's not
Weight
very
gain.
life threatening. That is not life threatening. Right? So Amreen Fatima has given a good answer, blood clot. So basically deep vein thrombosis. So DVT is extremely important and look for in any patient who is on tamoxifen. And Dr. Ansia also given the correct answer, endometrial carcinoma. So write down in your notes the two deadliest complications of tamoxifen is development of endometrial carcinoma. So how do you monitor, Dr. Ansia, that endometrial carcinoma? If patient is on tamoxifen, how you monitor whether endometrial carcinoma is developed or not? Especially in this patient, if this patient, just for understanding, if we put this patient on tamoxifen, right? Then how you monitor, Ansia?
The pap smear? No,
Pap pap is for
endometrial
you.
cancer.
Pap smear is for uterine cancer or cervical cancer.
Sorry.
Okay, so how you monitor endometrial carcinoma is developed
The
down the line?
endometrial thickness,
Okay, endometrial thickness. So how do you know endometrial thickness?
USG, ultrasound.
USG. Okay, before that, any symptoms develop, patient?
Bleeding, sir, menorrhagia.
Excellent. So that is what you want to answer. You are knowing everything, but make it little more organized. So any
Okay, sir.
postmenopausal woman on tamoxifen again start the bleeding. 68 is obviously menopausal. His menses is gone, right? So postmenopausal woman comes with the menses. First and foremost is endometrial carcinoma. Is that clear? Right? And tamoxifen known side effect is, so any patient who I see on tamoxifen on the breast cancer treatment, I number one ask first question in my OPD is, have you started your menses or do you have any spotting or any bleeding? No, my job is done. There is no. If she is saying postmenopausal, yes, I have bleeding, I have spotting, I have this every 2 3 monthly, I have some kind of bleeding, then I'm absolutely concerned and worried about that bleeding. Then what I'll do, first investigation, I do the USG, either transabdominal or transvaginal, try to check the thickness of the endometrial, And if it is suspicious, then I do endometrial biopsy. And this endometrial biopsy will confirm there is a benign malignant or nothing to worry. Is that clear? Yes or no? Ansia, are you getting my point?
Yes, sir. Yes, sir.
Right? So this is how we have to think, right? And what happens to the blood, Dr. Amreen? What happens to the blood? Why it becomes thick? Why the blood clots develop in this tamoxifen therapy? Any idea, Amreen? Fine. So everyone's homework, go and read the tamoxifen drug will 100% comes in exam. So tamoxifen is extremely important things. So don't underestimate this. So now just back to the question, right? So what is the answer of these questions again?
A. Lumpectomy with lymph node.
Okay, fine. Fair enough. Let's discuss other doctors. Fine. Yes, Saidi, would you like to comment anything now?
No, sir, I just stick on to that answer.
Chemotherapy plus lumpectomy.
Yeah, plus radiotherapy.
Plus radiotherapy. So just again tell me what are the criteria of giving the neoadjuvant chemotherapy? First of all, this is not just chemotherapy, it's a neoadjuvant. So what do you mean? There are two kinds of chemotherapies available, two kind of chemotherapy. Chemotherapy shortly is a two type, neoadjuvant and adjuvant. So neoadjuvant is a treatment which is given before surgery. So it is before surgery. So first before surgery means what? First you give the chemotherapy, reduce the tumor and then do surgery. That is neoadjuvant. Another word is adjuvant. Have you heard of adjuvant chemotherapy? So adjuvant chemotherapy is what? First you do the surgery, remove the breast lump, right? And then give the chemotherapy. So sequence is changed. In adjuvant, first surgery and then chemotherapy. Neoadjuvant, first chemotherapy and then surgery. So in this patient, I want to understand from you that why you want to give the neoadjuvant chemotherapy, or what's the advantage of giving first chemotherapy then surgery, or what are the criteria? There must be some criteria, na? Otherwise, why should somebody perform the surgery in breast cancer? Everybody will go for the neoadjuvant chemotherapy and then do surgery and thing. Anyone? Any expert? What are the
Sir, can I?
indication of neoadjuvant? Anyone? Yeah, please.
The tumor size should be more than 5 centimeter for the chemo, and
Okay.
more plus or minus more than or equal to, or nodes and mets should be present plus or minus. So
Wonderful. Excellent. So did you attend my earlier class or what?
I'm already used to your lectures. This is my answer. I already first answered what I made wrong, sir. I also made D, but you explain me
Okay, last
why.
time.
No, it was first lecture, sir. It was like 8 lectures before.
Oh, great, wonderful. No problem. Fine. So basically, now see the criteria, 68 years of old woman, so must be menopausal, 68, right? Her physician with solid peanut is at least 2 centimeter or so, hard mass in upper outer quadrant. So two questions, right? So hard mass is goes in favor of malignancy. As I told you, cystic mass is a benign, hard mass. Second, which is the most common. So in breast, there are 4 quadrant, right? Do you know this is breast, this is nipple, there are 4 quadrant. If you divide in 4, there are 4 quadrant, right? These are the 4 quadrant, right? And this is axillary, right? So this is upper outer, this is upper outer, this is a lower outer, this is upper inner, and this is lower inner. So amongst that, upper outer quadrant has the highest incidence of breast cancer. So this is again a clue, upper outer. So this is one question in exam. Which quadrant of the breast has highest malignancy? Upper outer, lower outer, upper inner, lower inner. Answer is upper outer quadrant. Hard mass. Biopsy is already proven, right? So what is the biopsy? Infiltrating duct carcinoma. So question in exam, which is the most commonest frequently seen histology in breast cancer? Answer is infiltrating ductal carcinoma is the most commonest. 70 to 80% patient will, right, having a biopsy report in their hand after doing the breast biopsy is a infiltrating or invasive. Both are same thing. Invasive means infiltrating. So sometimes histopathologists write invasive ductal carcinoma, some will write infiltrating ductal carcinoma. Both are the same things, don't get confused. Invasion and infiltration, same thing, right? So invasive or infiltrative. So this is most common histology. So a lot of questions, right? Hard mass, malignancy, upper outer quadrant, most common site, most common histology, infiltrative. Let's go further. What is the next step in the management? So this is a you need before answering any questions in oncology, any head to toe cancer, you must know the TNM. T means tumor size. So tumor size peanut, let's say it's a 2 centimeter. They have not mentioned anything about nodes. So T means tumor, and for node, and M stands for metastasis. So they have not mentioned anything about metastasis. Either we know there is no metastasis, or MX means metastasis is not known. So when we write the report, if somebody has in the oncology, they write P. P stands for pathological. Pathologically, T2 N0 means no node, and M0 or MX. M0 means there is no distant metastasis, or MX means distant metastasis. We did not did the workup, or we don't know. That is MX. So PT2, P means pathological, you did some surgery, tumor size is T2, right? So we'll see what is T1, T2, T3, T4, N0 and M0. So this is for the breast cancer. So let's discuss T1 is less than 2 centimeter. For your knowledge, less than 2 centimeter is a T1. What is T2? Means T2 more than 2 centimeter but less than 5 centimeter. Less than 2 to 5 centimeter is a T2. What is T3? More than 5 centimeter. Anything more than 5 centimeter is a T3. And T4 is either skin involvement, right? Skin involvement, or below muscle involvement, or chest wall invasion. This is the T4. So mainly the skin involvement. So T1, T2, T3, T4. Lower the T, better the prognosis. T1 is the most easiest, T2 more difficult, T3 more difficult, T4 very more difficult. So if I ask you which has a best prognosis, T1 has the best prognosis, worst prognosis, T4. Is that clear? So tumor size. So now here, if I can make a TNM classification of this patient, what is the tumor size? They have mentioned here, na? Solid peanut shaped hard mass. Solid peanut shaped means peanut, right? So they had given the peanut instead of centimeter. They have given peanut. So the peanut is around 2 centimeter, right? So peanut shaped hard mass, upper outer quadrant, biopsy is invasive ductal carcinoma. So I can take this as a not even T2, even T1, right? T1 max T2, right? Peanut, it may be different in size, but maximum T2. So let's take higher side, T2, N0, M0. So now if I can tell you that 68 years of female, right, with T2, N0, M0, right, or looks like a T2, N0, M0, what is the best treatment? Still, would you like to give neoadjuvant chemotherapy, doctor? Why can't you go for the surgery directly for this patient? Why don't you do the neoadjuvant chemotherapy for this patient? What are the criteria for neoadjuvant chemotherapy? Anyone?
So because
Yes.
infiltrating ductal carcinoma has got a poor prognosis comparatively.
Yeah, so all cancers are, as I told you, infiltrating ductal carcinoma is from stage 1 to stage 4, right? Even T1, N0, M0 have infiltrating ductal carcinoma, T4, N3, M0 has an invasive ductal or infiltrating ductal carcinoma. So infiltrating ductal carcinoma is whether stage 1 or stage 4, both have a common histology. So this is a bad, obviously bad. But for this, but the histology and stage are the different, just for your knowledge. So don't get confused. Histology means what you see in the microscope is the histology, and stage means what? Where the cancer spreaded from the breast to lung, colon, breast, brain, or other parts of the body. That is stage. Stage means how it spreads in across the body. That is stage. And what you see under microscope of biopsy specimen is a histology, right? So do you think this T2, N0, M0 is a very advanced stage or
No,
early
sir.
stage?
But I think by doing lumpectomy, we are able to preserve the breast. The conservative, I mean, we are not doing radical mastectomy is like removing the breast itself. There is no need for that. Only lumpectomy and
Yes, you are right.
adjuvant.
Going absolutely right.
Yeah.
So what's the answer?
So D is the answer.
D is the answer.
Sir.
Okay, but here neoadjuvant chemotherapy does not qualify. So, and why, if I can tell you, doctor, why not A is the answer then?
Yeah, that is my second answer actually, I thought.
So make it first answer,
Okay.
because I'll tell you the reason. I tell you the reason, scientific reason. Neoadjuvant chemotherapy is given to the patient who has a tumor size of more than 5 centimeter, nodes positive, advanced cancer like T4 or node positive, right? When the disease is absolutely localized. What do you mean by localized? There are three categories. Let me tell you. This is a breast, this is axilla. So if this is a nipple, so if the upper outer quadrant, this is a breast, right? If this is disease is only in the breast, it is called as a localized disease. Only lump in the breast, like this picture, patient. They have just peanut shaped lump, hard lump in upper outer quadrant, even no lymph node. So this is called localized breast cancer. Localized breast cancer. It's absolutely localized to breast, right? When it is goes from breast to axilla, right? Axillary level 1, 2, 3, different axillary lymph node involves. Now it is not localized. The name for this is called as a locally advanced breast cancer, LABC. We called in our medical oncology every day in our practice is a LABC. So you need to know this is little high. This is little LABC is more dangerous than localized disease. Localized is absolutely to the breast. If goes from breast outside, it goes first to the lymph node in the local draining lymph node is axillary lymph node, right? Then they may goes to supraclear, they may go to internal memory as well. But the first and foremost is the axillary. So there are three categories in breast cancer. One is a localized disease, which is absolutely localized to the breast. Second is a locally advanced breast cancer where it goes to the lymph node. And third thing is called as MBC, metastatic breast cancer. Third is a metastatic breast cancer. What do you mean by metastatic breast cancer? This tumor, it goes beyond the breast and axilla to any part of the body. Like upside is a lung, lower side is a liver, and laterally bone. So either it is goes in the lung, liver, or bone, and fourth common is a brain. So these are the four commonest site I have seen last more than 15-20 years. This is how they spread. So you need to categorize this tumor. So now tell me in which category it falls. In which category it falls? Local disease, locally advanced disease, or metastatic disease? Which disease is this? Everybody getting me or no? Yes or no? At least tell yes. So I thought that
Local,
okay.
sir.
Yes, sir.
So this is localized disease, locally advanced disease, or metastatic disease. Figure it out.
Local, sir.
Absolutely local, because there is a lump in the breast, no axillary, no metastasis, nothing mentioned, right? So when there is a disease, doctor, a localized disease, right, and small disease, especially less than 5 centimeter of lump, no need to give any chemotherapy, especially before surgery, no need to give chemotherapy. It will not add the advantage to the patient in terms of overall survival. When the chemotherapy is answer for this patient, when the CD is the answer, when it is more than 5 centimeter, where there is the axillary lymph node positive, when there is a triple negative breast cancer, then in that case the neoadjuvant chemotherapy plus lumpectomy plus radiotherapy is the answer. When whether it is a locally advanced disease, then this is the answer. But localized disease, you have just breast lump, remove breast lump, that's it. Why you want to give the chemotherapy and hair loss and making patient more traumatic physically and psychologically? Is that clear? Right? So correct answer is lumpectomy with lymph node sampling radiotherapy. Why not mastectomy? Because lumpectomy and mastectomy by and large the same result, but at small lesion you can preserve the natural organ of the body which God has given to the female, that is breast, right? So you don't need to remove the complete breast. You just remove the lump, do the axillary clearance, and followed by radiotherapy. Results are same, right? So nowadays we in our clinic we always try to preserve the breast. We always try to preserve the breast, which is a natural organ of the female, right? So we never go, okay, you have breast cancer, remove whole breast. Nothing. It's a very bad, na, cosmetically. Once the disease gets cured, patient has a psychological things. Oh, she has a no one breast throughout the life. So it's not good idea. Always always look for lumpectomy. The another name is a breast conservative surgery. The another name of the lumpectomy is a breast conservative surgery, where you are not removing the breast, you are just removing the lump. That is why it is called lumpectomy plus axillary dissection or clearing or sampling, right? So modified B option is not good option. Third option, modified radical mastectomy plus radiotherapy. So if you do somebody by, say for example, somebody did even MRM, then radiotherapy is probably not required for this patient because it's less than 2 centimeter, no radiotherapy, no node positive, no radiotherapy. So radiotherapy does not deserve, so it's not good option. This is absolutely not good option because it's localized disease, so chemotherapy is not required as a neoadjuvant in this patient, right? Otherwise, lumpectomy and radiotherapy A option is okay. And tamoxifen is absolutely wrong answer because they have not mentioned anything about ER/PR status. And if it is not mentioned, means negative. So tamoxifen will not. And radiotherapy, right? So you are here in E option, you are not doing surgery at all. You just do tamoxifen in this patient, you are giving radiotherapy. So you cannot replace the surgery with the radiotherapy. So surgery is a mainstay of treatment for any cancer, right? So tamoxifen and radio, because tamoxifen, why not? Because ER/PR negative, that is why tamoxifen not needed. Radiotherapy of frontline localized disease is nowhere done world over. First localized disease, surgery, that's it across the globe. Is that clear to everyone? Now question. Now question. Anyone? No question in the whole house. We have more than 30 people.
Sir, I have one question.
Yes.
Just last time we have discussed that tamoxifens are for premenopausal and antrazole for postmenopausal. I'm not getting that. Is that true, sir?
Yes, that's correct. That will come in the next slide.
Okay.
So your query will be solved.
Okay.
But tamoxifen and letrozole or aromatase inhibitor is for those patients only who have ER or PR positive. Here it's not positive. Then why you want to give? You understand?
No. Just a doubt, sir.
No, that's fine. That's a valid question. So I'll sort out.
Okay,
So, so this is what the thing is. So here the treatment is breast conservative surgery, that is called lumpectomy plus radiotherapy, standard of care for invasive cancer. MRM gives you no survival benefit and it's more invasive as well, right? So always try to look for all patients of breast cancer. If feasible, try to categorize localized disease, locally advanced disease, and metastatic disease. If it absolutely localized disease, think of breast conservative or lumpectomy, no MRM, right? There are 4 main categories: invasive breast cancer. So let me go and jump to the questions which I have prepared for you. One by one you can answer. This is quick questions, all related with the exams. I make it for you. What is the commonest histology in breast cancer? We all talk about breast cancer. What is the most common histology? Histologist, you do the
Infiltrated duct carcinoma.
invasive ductal carcinoma, IDC, or infiltrating. One answer is given. Bilateral breast cancer, common histology.
Invasive lobular carcinoma.
Invasive lobular carcinoma, excellent, right? So if they ask what is the most common histology in breast cancer, then it is a infiltrating or invasive, or which is a common histology in bilateral breast cancer, that is invasive lobular carcinoma. So there are two main. One, if it is cancer arising from the duct, it is ductal carcinoma. It is from lobular carcinoma. Before that, you need to understand the anatomy of the breast. So anatomy of the breast, when there is a nipple, behind the nipple there is a duct, right? Which, I mean, get the milk into the breast. So duct. So if the cancer arising from the duct, it is ductal carcinoma, and all the ducts connect eventually a balloon-like structure that is called as a lobule. So it's a lobe. If it is arise from the lobule, it's a lobular carcinoma. So ductal carcinoma, lobular carcinoma. No need to mug up. So go and see just the anatomy. Then you get to know, okay, where is the lobe, where is the duct. So commonest is ductal carcinoma. Bilateral, right, is a lobular carcinoma, that is invasive, and it is seen in almost 20% of the patient, bilateral breast cancer with the lobular carcinoma. So if somebody has a bilateral breast lump, right, so probably the histology will be invasive lobular carcinoma. Young patient modalities for the breast lump. Treatment of young patient modalities of breast lump treatment. First, if it is localized disease, as I told you, you go for lumpectomy. So you should not go for the MRM. Very sorry, huh? Something wrong in my. Okay, so this is a right. So breast cancer. Why mammogram necessary before surgery? Anyone? Why you want to do the
To rule out bilateral.
Excellent, excellent, very excellent answer. So rule out, right? So if your patient has a right breast lump, right, and you did a biopsy from the right breast, it is a biopsy, it is an invasive ductal carcinoma. Then why you want to do the mammogram? Because it's possible that patient may have a bilateral breast cancer, patient may have a lobular carcinoma, patient may present with the bilateral. So before performing the surgery, you must need to do a bilateral mammogram, right? Because probably right side lump is palpable, left side probably it's not palpable. It's not palpable, it's possible. So your management will be changed. If I tell you there is a one-sided breast cancer, and if I tell you there is a two-sided breast cancer, the management completely change in the mind of the surgeon. So you need to know whether it is a unilateral or bilateral, right? Most of the case it is unilateral, but around 2 to 5% they may present with bilateral breast cancer at the same time. So mammogram is mandatory before surgery just for one reason. Biggest reason is a mammogram. Why you want to do the mammogram? Unilateral versus bilateral. Second most extremely important is a unicentric or multicentric. What do you mean by unicentric or multicentric? Anyone?
It is in single node or multiple places it has been present. Multifocal.
Yeah, multifocal means one side or many multiple side, right? So single
Yes.
focal, that is unifocal, and multifocal means multiple side, right? So why it's important to know unifocal or multifocal? So if the
Depends.
disease, yes, tell me.
Treatment plan.
Right. So what treatment plan will change from unifocal to multifocal?
Maybe the lumpectomy, if it's not a solitary or a lumpectomy not needed, can go for the best conservative surgery or something.
True. So when there is a unicentric, means center is one in the breast cancer, you go for the lumpectomy. When there is a multicentric, means tumor is more than one side of the breast, right? Then you go for the MRM. So you cannot stick every time with the breast conservative surgery, right? Every time you cannot say with the 1 second, something wrong in my this thing. So I'll stop sharing and I'll again share. Great. So say for example, just better clarity, this one-sided breast, another. So this is nipple. So this is one center, only one side tumor, right? And here the nipple, and there are lots of tumor, lots of tumor. It is in upper outer quadrant. It is in a upper inner quadrant, it is in a lower inner quadrant. So this is multicentric. There are lots of tumors in one breast. This is called multicentric. Centers are multiple. And this is unicentric. Only just once find these things. So here the treatment is a breast conservative surgery or lumpectomy. Here you cannot do lumpectomy of 3-part quadrant. Better you remove the whole breast, which reduces the risk of recurrence. So this is why important, right? The biggest advantage is unilateral or bilateral, number one, and number is unicentric or multicentric. These are the two major key advantage of doing the mammogram, which probably change the diagnosis. Treatment. So if somebody tells me, sir, there is a multicentric tumor in the right breast, then I'll not happy with the lumpectomy. I'll go for complete MRM. Is that clear?
Yes, sir.
Great. So this is the answer why the mammogram is a ductal carcinoma in situ versus lobular carcinoma in situ. Can anyone tell me what is the treatment of ductal carcinoma in situ? So this is homework. What is a ductal carcinoma in situ? And what is the difference between ductal carcinoma in situ and what is difference between invasive ductal carcinoma? Invasive ductal carcinoma of breast, right? Or ductal carcinoma in situ of breast. What's the difference? Go and read it. Guideline for mammogram of breast cancer. Guideline of mammogram of breast cancer. Mammogram of breast cancer patient, first degree relative. So if I can give you one example, that uh, the name of the lady, right? That ex lady, right? She has a breast cancer, and her daughter is asking for the mammogram. How will you advise? That is guideline. Guideline of mammogram for the breast cancer patient's first degree relative, right? So ex patient has a breast cancer who is a 50 years of age, and now why is the daughter? She is asking, sir, when I supposed to do the screening for breast cancer? I am worried that my mother has a breast cancer. So when I supposed to start the test? What's the answer?
Age above 40, sir, if it is a first degree relative is positive.
Okay, okay, fine. So that's a perfect answer. What is first of all the like colon cancer, 50 years of age? Here the write down the common age to start for general population is 50 to 75 is a routine age for the breast cancer or mammogram to do 70, 50 years you start and do up to 75 colonoscopy every 10 years. This is every 1 to 2 years. This is 1 to 2 year. 1 to 2 year you need to do mammogram bilateral, right? This is for the general population like colon cancer. But what if it is a first degree relative? In that first degree relative, what we do in colonoscopy, instead of 50, we start 40, right? And every 10 year here, instead of 50, again the 10 years earlier. So you have to start at the 40 years of age. And again, the frequency is same every 1 to 2 years, right? So when there is a high risk, that is why the family history is important in the breast cancer. Because if somebody with the first degree relative had the breast cancer in family, they need to start the mammogram bit early, right? Just to pick up the early in the disease, right? So this is a guideline. So 10 years before the things. Any chemoprophylaxis for first degree relative of breast cancer patient. So this ex patient has a breast cancer, and why? Her daughter is asking, sir, do I need to take any medicine which can prevent the breast cancer because my mom X has a breast cancer? Is there any medicine that is called chemoprophylaxis? Any medicine?
Tamoxifen.
Yes, so this
Tamoxifen.
the answer is the tamoxifen. So tamoxifen reduces the risk of the breast cancer about 50 to 70% in a patient who has a first degree relative of breast cancer. So this is very important, right? Question number 8, male breast cancer versus female breast cancer treatment algorithm. Is there any change in the male breast cancer and female breast cancer? So
No,
probably
sir.
some doctors are confused. Oh, sir, are you talking about male breast cancer? Yes, I am talking about male breast cancer because breasts are present in both the male and female, but females are larger, males are smaller. But do breast cancer happen in male as well? And treatment modality is the same: surgery, chemotherapy, radiotherapy, hormonal, and targeted. The same way what we treat for the female, treat for the male as well. So no need to confuse. Treatment modalities would be the same. Algorithm. Mammogram age recommendation for general population, I told you 50 years, every 1 to 2 year. And common side effect of breast cancer drug, you must know, read, go and read it. Because of time, I'm not going much in detail of pharmacology of breast cancer treatment. But if you guys interested, do let me know. I'll tell you each and everything. So these are the quick common questions I gathered for you. There are lots more questions. There are hundreds of questions, but these are very common and high yield. So now come to the main table. This is the table which I created, right? Not in the any book, definitely. So this is for invasive invasive carcinoma of breast, right? Invasive carcinoma. This table does not apply to ductal carcinoma in situ. Ductal carcinoma in situ, right? That is called DCIS, ductal carcinoma in situ, and lobular carcinoma in situ. It does not apply to both the category. Lobular carcinoma in situ, right? In situ means very early, right? Stage 0, you can say. And then invasive after ductal. It if you don't do it well, the ductal will enter into invasive. So invasive is more advanced than ductal, right? So it's a very early. Very early is a ductal, and advanced is a invasive. So this all table applicable to invasive breast cancer. So TNM, as I told you, tumor size is less than 5 centimeter. Node is negative, and no distance metastasis, TNM. So it's a very early disease like that peanut, right? What we discussed, 68 years post-menopausal, peanut-shaped hard mass, upper outer quadrant, biopsy, infiltrating ductal carcinoma. What is our next step? Surgery. Why? Less than 5 centimeter, no node, no metastasis, right? So here the two type of surgery, breast conservative surgery versus MRM. Breast conservative is also as lumpectomy and lymph node sampling. That is called breast conservative. So this is the preferred for the early breast cancer, right? When the MRM is preferred, right? When there is a multifocal disease, you cannot do it. Breast conservative, multifocal. Another is the patient's choice as well. If patient is comfortable with MRM, you cannot force them to do the BCS. That is also another important thing. So this is surgery. When the chemotherapy is indicated or the neoadjuvant, doctor, you answered me the neoadjuvant, right? So neoadjuvant with surgery with radiotherapy. So neoadjuvant means before surgery chemotherapy when it is indicated as per guideline. So when tumor is large size, by giving the chemotherapy, you are making from large to small. So it's important. Operability is more easy and feasible. Number two, notes are positive, means it is a locally advanced disease, right? See, this is localized disease. Only in the breast, no axilla, no metastasis. So it's localized disease. This is locally advanced disease, right? Where the tumor size is more and also it goes to the axillary lymph node, means lymph node is positive or nodes positive, right? Mets may or may not present, right? Then you need to give the neoadjuvant. Here negative, rather I can say metastasis is not there. So lump is big, node is positive, you go for neoadjuvant chemotherapy and followed by the surgery, right? If somebody did already the MRM for this patient, then you can go for adjuvant chemotherapy, but ideal candidate, right? So what is you need to keep in mind before treating any breast cancer? Simple TNM. What is tumor? What is node? What is metastasis? Right? So if tumor is small and nowhere out of any part of the body, go for directly surgery. Breast conservative, it is larger tumor more than 5 or it's a node positive, or another category is a triple negative, ERPR and HER2. They are high risk patient. So in that case, you also go for the neoadjuvant chemotherapy. So these are the chemotherapy criteria. Radiotherapy, when you supposed to give the radiotherapy, when the tumor size is large, same as like chemotherapy, where you give the chemotherapy almost this all patient deserve. So if the tumor size is more than 5, you need to give radiotherapy. This is local radiotherapy on the chest wall or the breast. Local radiotherapy on the breast wall and axilla, right? You want to prevent the local recurrence. So tumor is larger, increase the risk of local recurrence. So you must give. If nodes are positive, you must give, especially when there is a no distance metastasis, right? And another one extremely important, you must remember, breast conservative surgery, radiotherapy is a mandatory must. Breast conservative surgery, any patient underwent for breast conservative surgery, you must give the local treatment, because there are few cells which probably left during the local excision will end up with the local recurrence, and to prevent the local recurrence, you must give the radiotherapy. What is the targeted therapy? Right, so targeted therapy is this is the breast cancer cell. On breast cancer cell, there are three receptors. One is a ER, estrogen receptor. Another is a PR, progesterone receptor. Third is a HER2, human epithelial receptor, new type 2. This is complete name, HER2, human epithelial receptor. Shortly we called as a HER2, right? HER2, right? So there is HER1 is also there, HER1, HER2, but this is HER2, right? So HER2, these three receptors are there. So if the ER present, ER is positive, you block this receptor and reduce the recurrence of the breast cancer. If PR positive, there is one drug available, you use it. And if the HER2 positive, there is a one drug available. So drug is available. If you block this receptor, then it will reduces the growth 1 to 2, 2 to 4, 4 to 8, 8 to 16. It prevents the growth of the cancer cell. So this is simple. Targeted therapy is what? When the HER2 3 plus means HER2 is positive, and when there is a HER2 is positive, you give the trastuzumab to the HER2 positive patient. That's it. No need to mug up where to give Herceptin or trastuzumab. The name of the drug which you give is the trastuzumab. That is a targeted therapy which directly target the HER2 receptor only. It blocks the HER2 receptor, block the cancer cell growth. And what is the hormonal treatment? Hormone, this estrogen is a hormone, progesterone is a hormone. So if the hormone receptor are positive, if ER positive, you give hormonal. If PR positive, you give hormone. If both positive, you give hormone. That's it. And what hormone you give? Tamoxifen and anastrozole or letrozole. If ER is negative and PR is negative, you don't give the hormonal because they are negative. It will not going to help the patient. If you stop the estrogen, which is responsible for the cancer growth. So if you stop the estrogen, you stop the cancer growth, right? So if you have ER positive, give the tamoxifen, that is anti-estrogen, two side effect, endometrial carcinoma and deep vein thrombosis, as we discussed earlier. So this chart I made it today. Earlier I used to write, but this chart I make it today a bit more organized, right? And it will be updated soon as well. Little more details are there, but I try to make it more simple. For GP level, we must know this, right? At least we know this. This is based. No book in the world, believe me, no book in the world this give the comparison. This is a general understanding. By my practice, how we treat, I created in a simpler way in TNM form. So if you remember this, then all the charts. So there are 5 treatments across the globe available for breast cancer: is surgery, chemotherapy, radiotherapy, targeted therapy, hormonal therapy. One more treatment is added in this is immunotherapy, right? But we are not going to much discuss. It's very advanced immunotherapy. Have you heard of immunotherapy? Yes or no? Yes or no?
Yes,
No?
sir.
Okay, great. Thank you for your answer. Great. So any question now? Now any question with this? Yes, any question? Priyanka, any questions? Toprak, Ajdani, any question?
No, sir.
So I tried my level best to simplify these things. So whatever the question they ask, if you remember this concept, TNM, just think over it. Don't, I mean, no need to confuse in the exam. What they are asking, you go properly, read the questions properly, you must 100% can give the answer. It's not a very difficult. So this is complete story of about these things. So I try to involve lots of questions. I'm not going much in detail of this. Everything I mention you in a simpler format. So I will share this PowerPoint so you can read it in detail. The most important prognostic factor in breast carcinoma is what? Histology, grade of the tumor, stage of the tumor at the time of diagnosis, status of ER/PR receptor, or overexpression of P53 tumor suppressor gene. The time starts now. Dr. Anita, targeted only for HER2 positive, sir? Yes. If you have HER2 positive, then and then you give targeted. If HER2 negative, don't give targeted. So targeted is not required for HER2 negative. Okay, Dr. Anita? Yes, Dr. Wajia, what's your comment on this? Most important prognostic factor in the breast cancer.
So that is TNM staging based on that.
Great. So stage of the tumor is extremely important, right? Irrespective of, all are important. Obviously, it's not one, but what they are asking, most important. So most important is a stage. So stage 1, stage 2, stage 3, or 4. Higher the stage, bad the prognosis, right? Stage 1 and 2 is a localized breast cancer. This is locally advanced breast cancer, and stage 4 is a metastatic breast cancer, as we discussed. Is that clear? Right? So higher the stage, bad the prognosis. So stage of the tumor at the time of diagnosis carries the prognosis. What is histology grade? So grade 1, grade 2, and grade 3. So I have seen that many doctors are confused between grade and stage. So don't get confused. Stage is right. Stage is where the breast cancer spread across the body from breast to lung, liver, bone, and brain. That is stage. So which, right, where longer the spread, bad the disease. Stage 4 means metastatic. Stage 1 localized disease. Stage 2, 3 locally advanced disease because lymph nodes are involved, right? So stage is important. Grade is what you see under microscope. So grade 1 is what? This is a cell. Just for an, this is a normal cell. This is a little distorted, grade 1. This is a grade 2, very bad. Grade 3 and grade 4, you cannot diagnose at all what cell it is, right? So this is a normal cell, right? This is normal round cell. This is grade 1. More differentiation or more dysplastic change is grade 3. Even more dysplastic grade 3 and grade 4. So grade 4 is bad, right? But rather grade is also prognostic factor. So this all prognostic factor, right? So if having a grade 1 is good, having a stage 1 is good, right? But amongst grade and stage is more important because it shows the spread of the disease throughout the body, and that is a more prognostic than grading of the things. Otherwise, all are prognostic factor. Grade is a prognostic factor, right? So sometimes you have grade 3 and stage 4, extremely bad. Sometimes you have grade 1, but stage 4, but grade 1, so not bad. But you have bad grade, you have bad stage, bad prognosis. That's it. Status of estrogen, progesterone, again a prognostic factor. Having positive ERPR is a good prognosis. Having negative ERPR is bad prognosis. But stage is again a most important. And overexpression of suppressor gene, again a prognostic factor. So don't get confused in exam. And that is why each and every patient, we must know the stage of the disease. Localize, locally advanced, metastatic. These rules apply to everyone. Each and every head to toe, any cancer, you can ask yourself what is the stage of the disease or how you categorize localized disease, locally advanced, and metastatic. What is the bad amongst all the three? Localized is bad, locally advanced is bad, or metastatic is bad. Which one is the most bad?
Metastatic.
Metastatic, obviously, because it is spread to the many parts of the body. So prognosis is poor, right? And that is stage 4. Next question. 34-year female after examining pap smear, you find oscus. What do you mean by ASCUS? Oscus is atypical squamous cell of undetermined significance, right? Atypical squamous cells of undetermined significance. That is called oscus. So you did a pap smear for female who is 34, and on pap smear result comes as oscus. What's your next step? Repeat pap smear, cone biopsy, HPV, colposcopy. Yes, Dr. Wajia, what's your answer?
So cone biopsy.
Why you want to do the cone biopsy directly? What is the biggest risk factor for cervical cancer? Like for lung cancer? Sorry, biggest
Yeah,
risk factor
human
is the
papilloma.
smoking. Biggest risk factor is the smoking. So for for breast cancer, biggest risk factor is BRCA1 and BRCA2, right?
Human papilloma virus.
Human papilloma virus. So why don't you confirm? What do you mean by oscus? First, explain me what is oscus and in which condition you see the oscus. So name the condition of the cervix where you can report. You can find a report as a oscus. Anyone, one by one. Anyone. Tell me the condition in which if I have a oscus, if the female has a oscus, what could be the differential diagnosis?
CA, sir. CA, sir.
Okay, so one is a CA, means CA cervix, right? Okay, so this is the only differential diagnosis in no other condition where you can see the oscus. Anyone?
Infection, sir. PID.
Excellent. PID infection. Second thing. What else?
Pre-malignant condition.
Excellent. Third. Fourth.
And malignancy.
5. CA means malignancy.
Yes.
So
And even normal, sir. Even normal can be.
right. So there are the few differential diagnoses of oscus, right? So it could be artifact. Oscus could be artifact, so it could be seen in normal. It could be a precancerous condition. It could be an invasive cancer, and it could be an infective or inflammatory disease of the pelvis. Simple. Not just infective, inflammatory as well, right? So these are the condition in which you can see the oscus. So you directly cannot jump. Otherwise, you may end up with some doing biopsy in a normal patient. So what you do, what is the main concern in Oscars for us being a doctor? We don't want to miss any cancer. Is that clear? We don't want any breast lump patient comes to me, what I don't want to miss, breast cancer. Any bleeding PR patient comes to me, what I don't want to miss is a colon cancer. Any dysphagia patient comes to me, what I don't want to miss is your esophagus. Is that clear? Yes or no?
Yes, sir.
So any patient with Oscars comes to me, being a doctor, being oncologist, what I don't want to miss is a cancer. So what I will first do, I'll go for HPV, because 95% of the patients are positive, right, for cervical cancer. Those who have cervical cancer, if you do the HPV testing, it's positive. Means what? HPV has a strong correlation with the cancer. Very rarely, without HPV, you get a cervical cancer, right? So in this patient, Oscars, it could be normal, it could be infection, or it could be cancer. So first, what I will do, HPV, I will do the HPV. Now there are two things, HPV is positive or HPV is negative. So tell me, doctor, what you do when this patient, Oscars patient, you do the HPV, HPV is present, what will you do? If HPV is negative, what will you do?
Colposcopy and biopsy.
Okay, so once HPV is positive, means now strong correlation. HP is positive, Oscars is there, you need to do colposcopy and biopsy. That is the answer. If the HP is negative, right, then what will you do?
Repeat after 6 months to 12 months.
Excellent. So again, you will repeat after little frequently. Otherwise, PEP is done every 3 yearly, right? But the
Yes,
PEP
sir.
is negative, but still you have doubt that this is a, though it is HPV negative, you still have a fear of cancer. So you do it frequently after 6 to 12 months. Again, you do PEP, right? Again, one more question
Yes,
in
sir. If it
exam.
is negative,
This
again do.
again, second time you are doing PEP. This all exam question. No? I am trying to compile all the questions, right? They will not ask you what will you do PEP. Okay, PEP, you do Oscars. Oscars, what comes? HPV positive, you do Colpo. If HPV negative, this all one by one question. A negative, you told repeat after 6 months. Again, after 6 months, again Oscars. Then what will you do?
Repeat after 1 year. Repeat after 1 year.
So you want to, you means to say you want to do third time, right?
No,
So
second time we'll do, and third time we'll do a biopsy.
so second time, first time you did it, Oscars, HPV negative. After 6 months, you did again again comes as a pap smear Oscars. Then what will you do? Second time, what will you do? Oscars, you need to do something, no? Or you don't want to do anything.
Sir, actually, for first time it is negative. We have to repeat after 6 or 12 months. If
Okay,
it is
and
negative,
no, if it is positive, I'm saying positive, then what's the answer? After 6 months, Oscars is again positive. It's not normal pap smear. Then what you do?
colposcopy and biopsy.
Exactly. So that is what I want to hear. So again, second time you go, you do the colposcopy and you try to do again, if possible, again repeat HPV. Is that clear? So this is guideline. So you remember and read from the book, right? I try to here I had given all detailed explanation in PowerPoint. So you later on see my video. Same virus responsible for cervical cancer. Answer is quick, rapid fire.
HPV.
HPV. Which strains of the virus is more common? Which strain? There are plentiful of virus strains.
16, 18.
18.
16, 18 and 611. So 16, 18 is the most commonly seen in 60 to 70% of the patient is a 16 and 18, and there is a vaccine available called as a bivalent vaccine. There are quadrivalent, which bivalent means two strain contain. They cover, right? Quadrivalent means four strain they cover. So I'll tell you that. So virus responsible is HPV. Which strain is more common? I had given one liner, but they give long scenario and they which is the most common. Is that clear? Right? So you should remember the number, recommended age for the pap smear and frequency, right? So there are two recommendation, right, for the things. If you are doing only pap smear, two question in one question. What first question is, right, recommended age. So recommended age is a 21, you start 21 year of age, you start pap smear doing and do up to 65 year, not 75. Remember, colonoscopy 50 to 75, breast 50 to 75, right? Now third comes is a cervical. So 21 to 65. Forget about 50 now. Very young age. You have to do, even being a female, being a doctor, if you never ever done your pap smear, I recommend strongly, because this is second deadliest cancer after breast. So every female, especially the medico, the doctors, they must have do at least once in every 3 years. And probably those who are sitting in my class is more than 20 years of age. So you deserve the pap smear. Every 3 yearly you do. This is one recommendation. If you are doing only pap smear, if you are doing only pap smear, do it every 3 yearly. If you are doing pap smear plus HPV, the same age, 21 to 65, but instead of 3 years, it's a 5 years recommendation. Is that clear to everyone? Any confusion? Yes or no?
Yes,
Are,
sir.
are you with me?
So I have a doubt, sir.
Yes, please tell me.
Sir, now you told ask us na, if we get in pap smear, low grade squamous intraepithelial lesion or high grade squamous intraepithelial lesion, so we can do directly colposcopy. At that case also we have to do this human papilloma testing.
You must do Dr. HPV if any abnormalities comes in the pap smear.
Okay, sir.
So this clear, age part is clear. 21 is 65 is absolutely fixed age. There is no alteration. But if you are doing only pap smear every 3 years, you are doing pap plus HPV 5 years. That's it. This is question. Cervical cancer vaccine schedule and age recommendation, right? You must know. If ask us what's the next step, we discuss. Best way of early detection of cervical cancer is a pap smear, and most common histology of cervical cancer. Anyone? Most common histology of cervical cancer, squamous cell carcinoma. Squamous cell carcinoma, right? There are two histologies, squamous cell carcinoma and another is a adenocarcinoma, right? So when ecto and endo cervix and ecto cervix meets up, that is called transition zone, right? Where the endo cervix and ecto cervix combines is a transitional zone where you can see the adenocarcinoma, but most of the cancers are squamous cell carcinoma. So these are the few quick questions about the cervical cancer, so you must know. So you cannot afford, your homework is to read complete first line to last line from MTB2 is a short summary is given. You read everything about each and everything. Whatever I discuss is the same thing, but again read it from book. This question will definitely come. It's a high yield. What is pap smear? Just one liner. Pap smear is used to screen the cervical cancer. Pap smear is usually done in conjugation with the pelvic examination. So you can't do, you just do the by gynecologist pelvic examination history and these things, right? And you can start the virus responsible is HPV, commonly sexually transmitted infection that can cause the cervical cancer. And in male, it also causes the colorectal cancer, right? So it's important. I explained everything, right? Oscus part again, I highlighted. Oscus is often found in female with inflammation due to early HPV infection. Approximately 10 to 15% of the patient with Oscus have pre-malignant or malignant disease, and that we don't want to miss. To pap smear reverse Oscus must follow with the colposcopy and biopsy. That's it. So if you have Oscus negative, again do 6 months. Again Oscus, go for colposcopy biopsy. That's it. Last couple of questions. 40 years old woman present with abnormal cervical cytology on pap smear suggestive of CIN3. The next step or next base step in the management is hysterectomy, colposcopy and lip, colposcopy and cryotherapy, conization. Yes. What's the answer? Yes, anyone? Dr. Kaushika, any answer? Kaushika Kalai.
Sir, colposcopy with and LEEP. B, option B, sir.
So you are Kaushika.
Yes, sir.
Wonderful. So what is LEEP means what?
Uh,
Don't Google, huh? Sorry.
no, sir, I'm not Googling.
Sorry. Yes. What is LEEP?
It's a electrosurgical excision of.
Yeah, you know that. I know that you are brilliant. Tell me why you hesitate. Yeah, it's a leap. Why? I mean, why you want to do this? First of all, what is CIN3? Do you know what is
Uh,
CIN or full form of
cervic-
CIN?
cervical epithelial neoplasm.
Sorry, what is the full form of
Cervic-
CIN?
cervical intraepithelial neoplasm.
Okay, cervical intraepithelial neoplasm. So 40 years of old woman present with abnormal cervical cytology and pap smear suggestive of CIN3, right? And what is the treatment of CIN1 and 2?
Uh, the- uh, I don't.
So that's your homework and send it to me, right?
Okay.
Your homework is how you differentiate CIN1, CIN2, and CIN3. What is the
Oh,
treatment of CIN1, CIN2, CIN3? I asked here CIN3, but if they ask you in the
okay.
exam CIN1, then what you do? You need to know, na?
Yes, sir.
Right? So that's your homework, right? Do
Okay.
it today after my lecture. Read it CIN
Oh,
chapter, open it from the book, right?
okay.
And tell me by tomorrow. You have 24 hours of time.
Okay, sir.
Wonderful. Anyone, any comment? Anyone? What is CIN1? What is the treatment of CIN1?
Sir, if it depends on, it varies on age, sir. If 25 to 30 years, then we have to do colposcopy and curettage. If it is 30 to 60 years, then we have to go for human papilloma testing.
It depends on dysplasia.
Yeah, but my question is only one. What is the treatment of CIN1? That's it. I'm
So I
not.
think it's laser therapy, leap.
So for 3 it is leap. For 1 it is also leap.
For 1 and 2 only leap.
1 and 2 only leap. So leap can be done without colposcopy or colposcopy is always there.
Almost.
Colposcopy is there.
It's always there to enlarge the thing and see.
Mm.
And easy.
Okay, so this is homework. I don't want to go in much detail. We'll discuss. So read what is colposcopy you read, what is leap you read, what is cryotherapy you read, and what is conization you read. For all 4 options you read, and not just the read where you do the conization. They will ask where you do the cryotherapy. They ask where you do the leap. They ask and what is the treatment of CIN 1, 2, and 3. That's it. This is what you want to do today homework. So this is what the thing is. This is absolutely normal. So this is normal epithelium, right? It is a histology of cervix, right? So this is a basement membrane. This is a basal cell, and this is I can say this is a squamous cell, say for example. So this is normal histology. If there is a one third of the thickness is involved, it is CIN1. When it is a 2/3 is involved, it is CIN3, right? More than 2/3 is involved, it is CIN3, and almost 100% of the histology is involved, it is carcinoma in situ. So how it differentiates carcinoma in situ from invasive? Here, if you can see, the basal membrane is intact throughout the things, and here the breach of the basal membrane. So it is gone beyond the basal membrane. Now it's invasive, and that is why it is called invasive carcinoma, right? Or invasive cervical carcinoma, right? So this is the thing. So CIN1, 2, and 3. So more the changes in the cell, more the grade or cervical intraepithelial. So another way it is called mild dysplasia. This is moderate dysplasia. This is severe dysplasia. And this is absolutely carcinoma in situ where there is 100% involvement with intact basal membrane. Here the 100% changes same as this CIN3, but the difference is here the basal membrane intact, basal membrane is gone. That's it. So this is invasive carcinoma and this is worst. Just for your knowledge, time frame, if I can tell you, right, this mild will go up to after 5 to 10 years, they will become the invasive, not in 1 or 2 years. At least 10 years, it will travel this journey to become from mild CIN1 to invasive. So if you detect anybody in CIN1, you may probably prevent the cervical cancer by treating here the CIN1. If you treat CIN, if you don't treat, it will go to CIN2. If you don't treat, go 3. And if you don't treat, go cervical cancer. And if you don't go through it, it will be a metastatic cervical cancer. So how easy to do the pap smear and prevent the life of the female by doing just the pap smear and knowing it is CIN1, 2, 3 or invasive. Is that clear? Yes or no? Concept is clear? Yes or no?
Yes,
Tell
sir.
me at least yes or no.
Yes, sir.
Wonderful,
Yes, sir.
wonderful. Thank you very much for feedback. So this is what you need to understand. Don't need to mug up. This is simplest way I try to collect the slide, picturize, so you better understand what is CIN 1, 2, 3, right? So higher the involvement of cell, 1/3, 2/3, more than 2/3, and complete 100% with breach of basal membrane carcinoma. That's it. So you need to remember here the answer is colposcopy and LEAP. LEAP is the treatment of abnormal cells of the cervix. LEAP stands for L for loop, E for electrosurgical, E for excision, and P for procedure. So it's a loop electrosurgical excisional procedure, right? And removes the abnormal tissue by cutting it away using a thin wire. So you use some loop or wire. That is why it's called loop. That is why L comes. What other use? You use the loop or wire. You use the electrosurgical. So you electrosurgically remove or excise by the procedure that is called loop. So you see the vagina, you see the colposcope, you do the leap. That's the treatment of the things, right? And here they're written what are the classification of CIN. As I told you, low grade CIN1 refer to a dysplasia which involves 1/3, CIN2 2/3, more than 2/3, and carcinoma in situ, cervical carcinoma. As I told you, which vaccine is more important? Vaccine effective, HPV 16, 18 is the most common strain, also 6 and 11, right? So these are the few common strains available. So you go and read it. Cervical cancer and breast cancer and colon. What I taught you today, you must remember, read everything. Another is question number 9. One of the most sensitive marker in lung cancer, LDH, CEA, beta HCG, CA19-9, CA125. Easy question. Yes, Kausika. Yes, so answer is a CEA, right? So answer is a CEA, carcinoembryonic antigen, right? So CEA is for lung mainly, and CEA is also for used for the colon cancer. So CEA used for two. This is called as a tumor marker. So lung and colon is CEA. LDH is tumor marker for is germ cell tumor, GCT, germ cell tumor. It is a marker, right? AFP, LDH, and beta HCG. So germ cell tumor, testis, and this ovary, germ cell tumor. Another is a lymphoma. Lymphoma LDH is a prognostic factor. Higher the LDH, bad the prognosis. So lymphoma, whether it is Hodgkin's or non-Hodgkin's. So lymphoma, LDH, and GCT both commonly used. Beta HCG, choriocarcinoma, and germ cell tumor, choriocarcinoma and germ cell tumor. CA19-9 is mainly for the hepatobiliary or mainly the pancreatic cancer or hepatobiliary cancer, pancreatic cancer, and CA125 is for ovarian cancer. That's it. So you must know the basic tumor markers. Is that clear? Is that clear?
Yes, sir. Yes, sir.
Right. So just go and open up the tumor marker. It's a very interesting topic and chapter. I love it, tumor marker. So we'll sometime discuss it at more in detail. So if you are treating a lung cancer patient, just follow up the CEA. If CEA on treatment going down, responding. If on treatment CEA going up, means it is a progressing or relapsing. Last but not the least, a female 30 years old breast cancer given a blood workup. and reveal low HB. Raised blood investigations are normal. What is the next step in the management? You do staging, you do lumpectomy, you do mastectomy, you do chemotherapy. And fifth, you do radiotherapy. What's the option? Treatment. Easy question, obviously. Yes. What's the answer?
Stunning.
I want to put each and everybody, last question. All people put the answer because more than half of the people not posting any answer. I'm looking for one wrong answer, but everybody's right answer. Great, I'm happy. Excellent. So no discussion. This is all completely the stage, as I told you, is the best prognostic factor. So this 30 years of female with the breast cancer given her blood workup. So she had given the blood workup. Now waiting. She has some anemia. So after the diagnosis, first what you do, you need to do in any cancer patient. This is a general principle in our practice in oncology. You do first the diagnosis of the patient. So diagnosis is done by the breast cancer. Once the diagnosis is done, second thing is a staging, which stage, and staging can be done with a CT scan or PET scan. So stage can be done for this patient, and one stage 1, 2, 3, 4 localized, locally advanced or metastatic done, confirm, then you jump on the treatment. So you don't need to jump on the treatment before stage, right? So you don't need to jump on treatment, mastectomy, lumpectomy or any treatment. Chemo is also treatment. First do the stage and then you jump on the treatment. So that's it. This is common principle. So that's all from my side from today. So it's time for little quick feedback for the today's session, and then we'll end up. Anyone, quick feedback. What you learned something new or exciting today? Or what's more interesting for you today? Anyone, quickly. I would be happy. So probably I need a lot of improvement to do my lecture because there is no feedback. So anyway,
No, sir, your lectures are really excellent.
okay.
We can't able to give such a amazing lecture actually. I just it was like mop up for me for the cold cancers.
Great.
Because the previous lecture also we had the same, but it was really a good mop up. Still, the revision should be in a good spot. But thank you so much, sir, for such a wonderful explanation and patience in each and every questions. No, sir, we excellent, sir. Thank you,
Right.
sir.
Wonderful. Thank you very much. Anyone else, last but not the least? Okay, great. So if you shy to give, yes, please.
Yeah, today I found that most of the questions are confusing. So we need to really look into the details. You taught us how to really analyze things. So most of the times we fail because of these confusing questions. So I learned how to analyze more, think, revise the questions. Like,
So it's a
thank you
good.
so much, sir.
It's good, isn't it?
Yeah, sure, sure.
Yeah, because what happened, we are always try to go for easier questions, right? Even I used to do that in my medical school. What are the easy? I'll go first that, and then I skip. I completely skip the odd one. And unfortunately, what happened when I skip the something that comes in my exam, especially my exam. So I was very depressed because I skipped that subject. So we don't want to skip any subjects, right? So I try to intentionally took some little controversial part, so that is why I can make some logic in your mind. Why this not, why this, why this not, why you need to do this, why this not, you understand? And sometimes many part is untouched for you, so I just try my level best to make this untouched part to little touchy part, right? So all is important. See, I'm not saying that whatever I'll teach you that comes in the exam, but say for example this chart, right? If I can tell you this chart, honestly speaking, it is so confusing and disturbing, this chart. Even I could not, even medical oncology, I understood for many years, believe me, when to give chemo, when to do surgery, when to give radio, when to hormone, when to this, that. Even after treating the patients and initial days of my residency and for my training, I was also confused. I was also confused. But gradually, by the experience, we figure out, okay, fine, this is the case, this is the TNM, this is tumor node metastasis, This is something tricky. You go for chemo first, neoadjuvant, and then surgery, blah, blah, right? So it looks very easy for you now to understand. Why? Because you have complete clear-cut, crystal clear-cut chart in front of your screen. Honestly speaking, if you find such a chart, do please share me. You won't get it. I made it today only just to make it more simplified for you. So rather than just I'm telling you verbally, I make one chart permanently so I can teach a lot of doctors, right? That okay, why? This is not a complete 100% complete chart. I'm not trying, but at your level or at GP level or MBBS level or for the clinical practice, if you know 90% of the things will be covered, believe me, 90%, right? There are few fine adjustments are also there in this chart, but that makes more complicated to you. And I don't want to make you more complicated. I want to give you general concept. Okay, when surgery, chemo, hormonal, radio targeted, hormonal is needed. If you know this, almost done. Is that clear? Anything else? Any last? Grasel, any comment? Okay, fine. So that's all. Yes, Grasel.
Very excellent lecture, sir. Very informative. And I have one more question. Will there be more classes on oncology, sir?
You say I will take more classes. It's my prime core, hardcore subject. So I love taking oncology throughout the year. It is endless subject. So we just touch
No,
the
sir. For exam, we need to prepare also for a lymphoma, leukemia, and all those things.
that
And all
was
we
that
need to.
was done. Hematology 2 lectures already been done. What you can do
Okay.
for time being, we'll take again. Don't worry. Feel free to anybody has any questions related hematology, oncology, medical oncology, or any other, right? You put directly to me. I am the expert of hemato-onco, especially. So you directly post to me. I will get back to you as soon as possible, right? With your queries, your answers, explanation, or I may call you directly and try to sort out your problem. But meanwhile, those who has missed the class earlier too, hematology and one oncology as well, you go on the YouTube website link. Everybody has a YouTube website link. I'll share.
Yes,
Anyway,
sir.
I will share in the group. So you go there. I had given with the date. Okay, fine. Right? This date, right? This is the lecture. This is the duration. So everything is there on the YouTube, right? So hematology class 1.5 hour, this date. So you go for the hemato-oncology class where I discuss excellent questions with same way. The what we presented today, every lecture is same lectures. So you enjoy 100%. So you just go through it. After that, if you have any more query, confusion, questions, concerns, just get back to me. Open for all. So I would be happy to guide all. Thank you very much. Thank you for your time. I'll just end these sessions and we'll see you again. Thank you very much. Thank you.
Thank you, sir.
Thank you. Bye bye. Take care.